trying to solve these issues and hopefully be able to entertain some of the different questions. And really the million-dollar question is, there's a lot of people using it, but is it really for medicinal purposes? If we cannot go onto a medical marijuana lecture without talking on the historical component of medical marijuana. Interestingly, medical marijuana has roots in which are already described in ancient Chinese medicine, where the Chinese healers have the word Dama. Oops, wait, you said this one? Yeah, Dama is the Chinese name for medical marijuana, and this is actually the tomb of a Chinese healer. And if you see next here in this bowl, when they analyzed it, they actually did find not only the actual seed of medical marijuana, but they actually found the actual pot, which is quite atypical. If you think about Chinese medications and all that, the most common one, and I'm going to speak a little bit to kind of like show up a little bit of knowledge, is Camellia sinensis, which is known to us as tea, and what we use of tea is the leaves. However, of marijuana, what we use are the actual pods, the seeds, the part of the female plants, and that's what they had in this old Chinese healer burial site of many centuries ago. Fast forward to many, many years, 3,000 years later, and the first report of medical use of marijuana comes from O'Shaughnessy in the literature in the 1840s, where he actually described multiple properties of marijuana as being analgesic, sedative, anti-inflammatory, antispasmodic, and even anticonvulsivant. Interestingly enough, it was listed as an active medication in 1850, so like 10 years after O'Shaughnessy described it in the medical literature, and it was listed there as a medication until 1931. Moreover, extracts of marijuana, like this one here, and this type of preparation were the number 1, number 2, and number 3 most prescribed medications from 1842 to 1890, okay? So the amount of use of medical marijuana was huge. Now, there is some problems when we start looking at the way that medical marijuana behaves. The first one is that the actual cannabis plant comes in several varieties. We do have one plant called the cannabis sativa. I keep pressing the wrong button. The cannabis sativa, which is a fairly tall, slender plant, which it's mostly a stimulant, is the one that tends to be related much more to euphoric events and all that. We're going to talk a little bit more on this. The cannabis indica, which is the one that is more described as the downer type of plant, and a rarely used cannabis ruderalis. We don't know much about ruderalis. It's a fairly not very common type of hybrid. Mostly what we see now in the common preparations are sativa and indica, and connotations of both of them in which they mix them in order to prepare some of the different extracts, like the one that you see here, and many of them that we're seeing now in the common market. What happened at that time? What happened in the 1900s? So in the 1900s, we started to see the development of multiple new medications that were very targeted for those days to certain receptors. We started seeing the opiate approvals when we started to see that there were barbiturates, aspirin, chlorhydrates, and a lot of these medications started to come into play. And then by 1937, put yourself in the historic context of what time we are living at that time, and that's a point in time when prohibition was coming to an end, okay? And they started to need some new targets, and that's where Congress came into power with Harry Einslanger, one of our famous congressmen, that he picked marijuana as his next target, as prohibition was coming out of his favor, and he was a famous prohibitionist. So he started to kind of like target marijuana as his next level of substance to be prohibited. 1937, they decided to start taxing $1 per ounce of medicinal use and $100 per ounce of recreational use of a substance that was widely available all over the market and fairly used. The American Medical Association was the actual only institution to oppose to those restrictions because they said this is a drug that is being used, reported, and medically and scientifically validated. And at that time, Einslanger was able to push for restriction of future investigation and delist marijuana without any clinical evidence and without any issues of toxicology that they were ever able to put in 1942, completely delisted. In the Act of Congress, when Harry Einslanger put to be kind of like banning marijuana, and just again, put yourself in context of how would it look if Congress would pass this now, and it's actually taken from the extract of the Congress session where marijuana was delisted. It reads, marijuana is is the most violence-causing drug in the history of mankind. Most marijuana smokers are Negroes, Hispanics, Filipinos, and entertainers. I don't know which one of those groups I want to belong to. I'm probably, there is satanic music, jazz, and swing results from marijuana usage. This is taken from the actual Act of Congress where marijuana was delisted. So this is not something that I just wrote or that he said in a speech. This is said in the chamber of one of our most beloved institutions of this country, or we will say, I don't know. By then, we keep fast forwarding, 1970, the National Institute of Drug Addiction started to be tasked with the kind of like asking the public, how do we classify drugs? What's a Schedule 1? What's a Schedule 2? Where do we put drugs as drugs were coming into being abused? Because again, 1970s, this is the era where people were abusing drugs, and the National Institute of Drug Addictions create two schedules. Schedule 1, where it says a drug that is for a potential of abuse very high, medicinal use no, and not proven even under medical supervision. So a drug that has no use whatsoever to be used in any other circumstances. And then Schedule 2, the ones that still have a high potential for abuse, but they do have medicinal use, even though that they may generate dependency. Look at the drugs that are listed in Schedule 1. Heroin, LSD, mescaline, GHB, and marijuana. And in Schedule 2, morphine, which at the end is a derivative of heroin, fentanyl, which is a synthetic form of heroin, amphetamines, codeine, etc. So that's 1970 when we were. Now, the federal law, what does it say? It still passed the Controlled Substance Act by 1970, and it made no distinction, which is still the federal law of this land up to this day. Federal law still is this one since 1970. Where there is no distinction between recreational and medicinal, with up to 1 year of prison and 100,000 of the first offense and possession, and up to 5 years in prison and 250 for cultivation and distribution. There's a lot of people from the 70s and the 80s that for repeat offenses and all that are still in jail out of marijuana cultivation or anything like that from these days. The Supreme Court actually had a case on this where they said that the medical need is not an excuse to break the law, and this refers to marijuana by itself. And this was 2001. We're not that far from today. So this is where we are sitting nowadays, and the FDA reaffirmed in 2006 that marijuana is not a medication. And I'm happy to tell you that we're fighting already this. We have precisely with one of the booths that are exposing today, an IND, an investigational new drug application with a number already for a use of a cannabinoid derivative extract for the use in cancer patients, that it's moving through the process in the current year, actually. Now, what's the problem? The problem is that the modern medical use, and we're going to start to get now medical, there's an old program in which they took 100 patients eligible to apply for medicinal use. There's still some of those patients still receiving these cigarettes from the government as part of the program of the investigation, even though that the program was terminated in 1992 due to the high number of applicants. The problem is that NIDA, the National Institute of Drug Addiction, is the one that has been sending these cigarettes to the patients. This is actually the leaves out of a cigarette that came out of one of those patients. Again, I told you that the Chinese healer had pots of the female marijuana plant, and look at what the people are getting from the National Institute of Drug Addiction. Stems, leaves, and a bunch of other stuff that God knows what that makes. If I tell you that I'm going to make a study of alcohol for something, and I prepare a wine out of leaves and stems of the vine instead of the grapes, how many people will drink that wine? So that's where our government is standing up to this moment. By 1985 and 1992, the FDA approved a synthetic preparation of dronabinol, marinol, for the use in cancer, cachexia, and HIV patients for nausea, vomiting, and weight loss. Dr. Cortez mentioned on these topics. Since then, there's been 2 other drugs, Navalon and then Rimonband. The study actually was interesting. This one, and I'll talk a little bit on the way that it works, but if you're talking all the time, you hear all the time that I'm talking about cancer, weight loss, appetite stimulation, the munchies of people that smoke marijuana and things like that. Why can I not get a synthetic drug the same as what they did with dronabinol and make a synthetic medication that will block those receptors so I can lose weight, so I don't get appetite? Great idea. There's a big, big problem. When Raphael Mechoulam in Israel described the internal receptors of marijuana in the brain that we do have. We have those receptors of cannabinoid substances in our brain, and he described that they exist. The person that described the receptor has naming rights, and he put to the receptor anandamine. And anandamine is the actual substance, and it's a Sanskrit term that it was used to refer what marijuana produced on the people when that receptor was stimulated, meaning in Sanskrit of anandamine, pure bliss. Guess what happened when we block that receptor synthetically to try to lose weight? Suicide. That's the problem. So that's the reason that nobody has had the great idea of blocking it anymore. And you see that everybody talks now of all the other effects, and nobody's thinking like, hey, what happened if we do it on the opposite direction? How's it going since then? Let's talk. 2006, the FDA already decertified it. What happened since the FDA said it's not a medication? It's nothing. Don't keep doing it. It's crazy. It has become the most common illicit substance in the general population. By 2011, 7% of the patients have referred that they are chronic and common users of marijuana. People over the age of 18 to 25 refer that have used it at least in 19% of the overall populations, and 48% of the general population had said that they have used it at some point in their lives for one reason or another one. We're talking, ask the same question for alcohol, and you may get numbers that are not that different of how many people have used alcohol for one reason or another one. Now, why are people using it? People are using it still mostly for fun. 47% of the patients refer that they just use it for fun. Again, no different than alcohol probably. 30% have been for only medical reasons, and 23% it has been mixed. Now, what are the medical reasons that we use it for? Pain still is the number one reason. That's actually what we're conducting the study at Sinai. Sinai, we're going to be conducting a study of chronic opioid users from cancer pain to see. We know that the patients that have chronic cancer pain, the pain keeps escalating as the cancer grows or anything is happening, and we want to see if with a preparation of a cannabinoid, we could keep the narcotic dose stable. Now you would say like you're changing one drug for another one, with the difference that the drug that I'm changing is a drug that causes many side effects like constipation, sedation, delirium, for a drug that might cause some other stimulating effects like euphoria, and when we see grandpa in a bed that doesn't want to stand up because of my chemotherapy is giving him fatigue, as Dr. Cortez mentioned earlier, then sedated from the narcotics and all that, and I give him something that decreases the amount of requirements of pain and then stimulates the patient, it might be a desirable effect. But it's still used by the same token for insomnia, because I told you sativa is a stimulant, but indica, it's a downer. It could be used as a sedative. It is phenomenal. I have used it in a lot of my patients, and it is great when the patients have that level of anxiety and that they cannot go to sleep to use some of the cannabinoids for insomnia. It is great, but then keep going down the list. Nausea, it is also a great medication, and even for depression, as we were talking earlier. Now, what are the reasons or the chronic medical conditions? And this is an old slide, and I'm sure that it has changed dramatically. Only 1.5% of the patients that were using marijuana in the 90s and early 2000s had cancer. That being said, when in 1991, they surveyed oncologists and asked if they have ever recommended marijuana to one of their patients, 44% of the oncologists, 1991, said that they had recommended. I can tell you that now that number is probably 90 to 100%. That at some point you say, like, come on, give it a shot. Okay? Now, there's a problem. We walked into a dispensary, and this is pictures from an actual dispensary in California where they sell some of the marijuana hybrids, and this is what you find. No difference than Starbucks. So you walked in and you've got the blondie, French roast, whatever, but you have all these type of things, and if I ask somebody that doesn't really know what they're going to get, if I tell you, like, okay, I would like you to go and get some OJ Kosh, Girl Scout cookies, things like that, you're going to look at me like, what are you talking about? So, and it's difficult, actually. I haven't been recently to the experience of needing to secure, let's call it, some product from California for my mother. When I called my cousin that is an OBGYN in California, and I said, do me a favor, go to the dispensary, I need you to get me a sativa 1-to-1 ratio at 14 milligrams. I gave him all the instructions, and the guy was looking at me, he's like, yeah, I walked in, and the guy told me, well, I got Girl Scout cookies. and I said, let me figure out which preparation do you have, and it's not that easy. And the menus are extensive. The menus are extensive. I can tell you, it's not simple. The second problem is that we always talk about the main components of marijuana. We always talk about the cannabinoids in marijuana. The cannabinoids in marijuana are this amount of what it's actually on this pot, which is the actual part of the plant that we use for extractions and all that. There's over 400 chemical compounds. And the highest concentration in those resins tend to be of delta-9 tetrahydrocannabinoid, but there's 70 additional cannabinoids. And the delta-8, which is a different type, that ends up converting in the liver, it's completely different. But the balancing between those cannabinoids, and I'm going to show you in a second what happens, as well as the terpenes and the flavonoids, are what really end up giving you the actual components of what you end up enjoying, using, or medicating from the plant. If I tell anyone here in this room, I'm going to put 2 bottles of wine from the year that there was an absolute drought in California, that the grapes got dried like crazy, they're super bitter, horrendous wine, it's $10 a bottle, and the next year when there was flooding all over, super sweet grapes, those grapes, the bottle is $100, same wine, right? Same vines, same grapes, same winery, and same extraction. That's a problem. The same happens with these plants, and that's the reason that control situation of how do we grow all these marijuana supplements, it's an art, and it's not that simplistic. The cannabinoids, the usual one, when people talk about high THC and low THC, they're talking only about the 9-tetrahydrocannabinoid. That's when they say, oh, that's a low THC or a CBD or a hemp plant, which is from the family, but not really cannabis. That just means that they have low 9-delta-tetrahydrocannabinoid. But CBD is the cannabidiol, which appears in some other plants, such as hemp. And you could have huge amount of hemp, full spectrum of a lot of the other substances. CBG is super active in a lot of medical applications, but different plants, again. Now, what's the biggest problem? In the liver, when we ingest cannabinoids, the hepatic metabolism converts that 9 tetrahydrocannabinoid, the delta 9, into 11 hydroxytetracannabinoid. That oxidation ends up being excreted in urine and feces with a half-life that is super fast of 20 to 30 minutes. That being said, if it's smoked, and I'm going to show you the difference in between ingesting it in a gummy bear, edible, or smoking it, because this is liver metabolism. It's called the first pass for the ones that are medical savvy, and it happens very different. CBD, the cannabidiol, it's what regulates that. It's kind of like the one that ends up moving the metabolism of the THC from one side to the other one. And there's actually 2 types of receptors, CB1, CB2. They're in different places of the body, including the immune system. It's very interesting, and I might want to pursue later some studies of immunotherapy and cannabis, because actually macrophages have cannabinoid receptors. And as we're talking of immunotherapy and cancer, I don't know if there was a lecture of immunotherapy earlier, it is actually quite interesting in the way that this receptor, mostly the CB2, might interact with immunotherapy. It is also an activator on the liver, and the way that it works, and this is kind of like a cartoon showing on the presynaptic level that as you go, let me see how this, yes, as you go into the postsynaptic function, the CBD and the cannabinoid receptor end up blocking, so no more tetrahydrocannabinoid reaches the point. So you could almost have an antagonistic effect, and that's the reason that having a good balance in between the two of them makes a lot of sense. And you regulate one with the other one. So when you see preparations that are super high in THC, super low in CBD, you might end up losing that is very, very actively regulated in our bodies, in our brains at this specific moment. I'm hoping, because since the cannabis is the pleasure part of the receptor, I'm hoping that this lecture is being somehow pleasurable, so that you're getting stimulation of this receptor, but regulated by these other receptors, so that there's not that amount of euphoria, so that people are not dancing like hippies during the lecture. Okay? So that's more or less the way that these receptors kind of like interact, but that's only 2 of the 400 compounds. And all the other components of the plant, we have not been able to study that well. And this is actually present all through the brain. It's in the basal ganglia, the motor activity. When I remember I had a classmate in school that we used to call the Muppet, because he was all the time like grooving and all that he was getting a lot of his basal ganglia getting stimulated. The people that get the munchies is getting it through the hypothalamus. The people that feel like, oh my God, it feels so great, they just got their nucleus accumbens stimulated. And it keeps going on and on. Even the short-term memory and the coordination, but you see pain at the dorsal aqueductum and all that. And the one that is of my interest at this time, CB2, immunomodulation. It might have a role that we have not studied at all. What are the problems? So everybody's saying like, oh yeah, it sounds great. The next thing after sliced bread, is there any problem? There is some problems. The first problem comes that a lot of these receptors are not fully developed until the end of teenage years. There is a syndrome that has been described on kids that use marijuana or any of the derivatives. Bear in mind that actually I used the term marijuana, that it was a derogatory term that also Congress used to put it kind of like a Hispanic name, and they were trying to make it the connotation that it was not good, but it became quite common now. But in the preteen years, that development of that reward mechanism has not been fully developed, and there's actually a few syndromes that have been described in pre-teenager years, at which if they use marijuana to a certain level in those years, they lose those reward and pleasure receptors, and they become what we call in psychiatry anhedonic, that nothing gives them pleasure, and it's been very widely described. And that's the reason that we do believe that high THC preparations should be kept to a certain level out of the reach of pre-teenager years. Pre-teenager, we're not talking even teenagers, we're talking pre-teenagers. So, I don't know, I think that's something that it's important, okay? The non-cannabinoid effects that we were talking, it does have an interaction with the mu and kappa receptors that are also part of the receptors of the pain system. That again is what we're looking. There's activation in nicotinic receptors that interacts with heart rate and things like that. I'm going to talk about that a little bit. And there's a lot of other effects, again, the ones on the immune system, but there's even proliferation of prostaglandin, that it may even stimulate the amount of even gut epithelium for patients with mouth sores, mucositis, and all that stuff. We're trying to figure out exactly what's in each one of the preparations, and there's a lot of technology that we've been able to now analyze what is on the different dispensaries in the different states where it's completely legal, and even here in Florida, and you can find out exactly what's the percentage of all the different things and the total amount of cannabinoids that they have. But the pot that we are seeing now, the marijuana that we're seeing now, is not your dad's pot. What the people used to smoke in the 60s, that they would just grow in their gardens and things like that, the amount of THC average of the concentration to what we are seeing now in 2007 has really gone exponentially high. And that's problematic. I don't know if it's completely good. It's good when we concentrate. But if I take a bottle of wine, and I keep using wine as a reference because it's an easy comparison, I could distill wine to the point of making it into cognac every single time. How many people would want to have a bottle of cognac every single night with dinner versus a bottle of wine? Yes, it's great. It's of higher potency. It's of different use. And I don't want to get everybody alcohol at the 50 and 70% proof when you can enjoy wine at the 8 to 10% proof where wine stands. And that's what is changing in marijuana. So they really have worked to grow it different. And this is actually quite interesting to me because you see a lot of the marijuana growers and all that, and they kind of like say, you know something, this is a green industry, this is non-genetically modified. Not really. They really have been modifying it like crazy. They've been increasing the concentrations to levels as high as 20% on the plants. The pharmacokinetics, meaning how the drug behaves in our body when we use it, it is also different when we inhale it. So the inhaled marijuana products, and this is something that has not been fully studied with oils. This is when we talk inhaled, we're talking of the leaves, which now in the state of Florida, as of 2 weeks ago, is legal. Now we could tell the patients, go to the dispensary and buy the actual plant and smoke a joint. This is what these studies are. The bioavailability means that 50% of the dose is being absorbed, getting into the patient's body. 50% gets exhaled out of what we call the dead space. The concentration, you can see that it's really, really high in minutes. And then it's super close, as if we would be giving it IV. This is amazing. There's very few drugs that you could inhale and get this curve that IV marijuana versus smoking marijuana gets to a level that it's that close. And repetitive doses do not really keep increasing the levels because the receptors get saturated, and as you repeat the inhalations, intervals of 1.5 hours, of doses of 2, 4, and 6 inhalations get to the same level, and the inhalation of the actual resin, the pod, the hashish, however you want to call it, even if it's not a joint, even with these fancy volcanoes, which a lot of my elderly patients prefer to use than just smoking a joint. And the amount that you have to volatilize it, so how much do you have to light it? Because a lot of people say like, oh, maybe I could just warm it up a little bit in the room with one of those diffusers and all that. Marijuana needs to be decarboxylated in order to release the resins, which means 140 degrees Celsius. That's actually something that all the people that have worked a little bit with the product know that they need to really raise the temperature up to the point of 140. When you keep passing 140, you do not extract tremendously much more to temperatures of complete combustion, meaning burning the leaf completely. So if I take a bunch of marijuana and I throw it into a fire, there's a point when I start losing some of the other substances and concentrating the THC no more, okay? So all that you need is really decarboxylation. Orally is very different. The gummy bears, the brownies, whatever you have heard about it, nobody has used them, but everybody has heard about them. But the bioavailability of those, different from the one that I just showed you, that it's minutes, 20 minutes, or something like that when you inhale it. When you ingest it, it takes, first of all, third of the drug gets degraded in the gastric lumen, only 5 to 20% gets absorbed, and the concentration peaks 1 to 3 hours later. This is a problem because the kids in college that want to experience and to try it take a gummy bear. That doesn't do anything to me. Let me get another one. That didn't do anything. Let me get another one. Let me get the whole packet. And then 2 hours later, they're stuck to their bed like, whoa. Because that's when it peaks. While if they would just smoke it 20 minutes later, they will be in anandamine, in pure bliss. The second problem is that look at this, the elimination might take up to 25 hours, while the elimination of the smoked, it takes somewhere around 2 hours. So the effect is much shorter. We've seen a lot of people that have consulted with, even on different levels, that have been actually in high productive industries where they say, I need to get a pass to be productive, I need to get to this meeting, get to this brainstorming session, and they use it for a production level, and then they keep going on. Is it healthy or not? I leave for others to judge. Not my field of expertise, but that's kind of like where we are. Doses are important. And the doses, we consider a low dose less than 7 milligrams, an intermediate dose, which is what we use mostly in our field, 7 to 18, and a high dose more than 18 milligrams. And if you remember the slide that I showed you, that the current pot is not our parent spot, most of the preparations are coming now in 20. They're all coming in more than the higher dose. And the tolerance, meaning when do you kind of like stop getting an effect, it's much more if you use low and chronic doses. So the person that says like, oh, let me get a pass of maybe a little bit, 7 milligrams, not much, let me keep getting it, they're never gonna get it because they're saturating the receptor at a chronic low level. While the person that uses a medium to a high dose just once for whatever they need at that specific moment and then they don't use it on a chronic level, they're gonna be fine, okay? But even when you look at, and I keep taking labels, I'm a label reader all over. Like the people that know me in the office, even when I'm eating, that I always turn things around looking at the labels and all that stuff. But when you look at the labels of marijuana, this is what you're getting, that if you get a bag of actual plant, you're getting 20% THC on a net weight of an eighth of an ounce or 3.5 grams. And that's all that you're getting. This will probably last several days to a person, while this chewable, 50 milligrams in a single dose. It's huge. It's a lot. And that's actually what we're seeing. We're seeing that in the pre-rolls versus the different cookies and oral preparations. Look at this. I couldn't find a dose of an edible in a dispensary that I took this list from. Then this is old. This has to be at least a year old or even 2 years. I couldn't find any that was in intermediate levels of the edibles. Everything was high because everybody thinks that more is better. And that's not the case with this. Now, what are the pharmacodynamics? What happens to the patient? Because the patients will ask me, like, what am I going to feel? They do get an elevation of the heart rate. There is a little bit of tachycardia. Again, the nicotinamide receptors that I told you earlier, the subjective euphoria, which could be good, could be bad. They might decrease alertness. For some patients, there's motor stability. And in males, it decreases luteinizing hormone, follicular stimulating hormone, prolactin, and growth hormone. That could be very good because it might increase also testosterone levels. So those levels are mostly female hormones, the growth hormone. In females, they actually have an increased sensitivity to THC, and they actually end up having increased levels of estrogen. There's a lot of studies of vasomotor events and things like that to see if they could be mediated by the amount of THC, but also, again, so in males, it might stimulate the testosterone production, and in females, the estrogen production. Quite interesting that it varies that much in the type of stimulation. And the models are reproductive of all the different levels that you could see on the heart rate or for how long does it last. And this is quite short. It's actually 4 to 6 hours with a heart rate that didn't really peak more than 120, feeling high, weed inhaled. It never lasted more than 8 to 10 hours, even after repetitive doses. This is repetitive dosing, and the alertness also decreased. Now, what is the toxicity? Because I've been telling you a lot of the good things. Is it toxic to the person? I show you in teenagers that there could be some issues. What is the toxic level of THC? Nobody has been able to find it. There is no toxic level. If you look at the toxic level of other substances, look at alcohol. The toxic level for a ratio of a fatal dose to an effective dose, when the kids do the 21 shots when they are becoming to an age of drinking, that we wish that they drink at 21. I don't even know why, because when we started drinking at the age of 12, but that's different. But when the kids do those shots and they drink 21 shots at one because they, are you 1, are you 2, are you 3, and they took 21, there's actually deaths reported from those 21 shots, which actually are a bottle and 2 extra shots. So when they drink a bottle of whiskey in 21 seconds, there's kids that die from alcohol overdose, because the dose is here, 10. Oral alcohol dose to a fatal ratio is 10. The dose of marijuana, it's not been reported. That is the reason that deaths from alcohols and deaths for cigarettes are all over our cemeteries, and we're still waiting for the first marijuana death. There's not been reported, not ever. Looked in the literature, looked it up, and there's never. Now, the second question is, because I had this discussion with one of my partners in my office. He said, that's a stepping stone. The marijuana person will use marijuana, will want to have something bigger, then they would want to have something more, and they would like to step into more. So is there a potential for dependency? That the person will say, like, I cannot function because I have not had my puff and my shot of marijuana today. This is the lifetime risk of dependency of a person from marijuana. The lifetime risk of a person that takes a cigarette, one cigarette, and says, let me try it, is 1 in 3. 32% of the kids that say, let me try a cigarette, let me try a Juul, let me try one of those garbage things that they're selling nowadays, 1 in 3. Heroin, 23%. Alcohol, of the person that says, like, I'm liking this alcohol, and that's the reason that we want to keep our kids from trying alcohol until late, like if that would help at all in dependency. But 15%, 9% of the users. I showed you earlier that 48% of the people in the country have said that they have used marijuana at some point in their lives. But the number of people that are dependent on marijuana, that they say, no, really, I cannot get my eye opener, my day started without getting a shot of marijuana, making one quick pass and then going to the office, or finishing my day and relaxing with a dose of marijuana, only 9%. The lowest of all the substances, and that still is listed as a Schedule 1. Okay? Is there potential for research? You name it. I think that there is potential for research in all the different fields. It's got a lot of different things that we would love to see. There's a lot of approved already preparations, from anti-seizure to Tourette syndrome. There's some ongoing clinical trials. Most of them are still mandated by NIDA. When I applied to the FDA to get my IND with the marijuana preparation that we're trying to do research, it was the second only ever in the country to be applied for from the FDA. I said, until now, until this year, if I wanted to do research with marijuana, I had to get first, before getting to the FDA, an application through the NIDA, the National Institute of Drug Addiction. And I said, you know something? The heck with it. I'm going to try to circumvent the NIDA and apply through the FDA directly. And we did it, and we already have an IND number, and we're moving ahead, and it's going to be one of the further clinical trials. But the data still is something that we would like to see much more, even though that the early studies of placebo for neuropathic pain and things like that, of just a few puffs of marijuana, are amazing, are unbelievable. You look at these curves and you see the placebo curve versus the low and intermediate dose of marijuana doing unbelievable. And you see, you don't need the high dose. You could just go even with the light dose for neuropathic pain without getting tremendous amount of the side effects of feeling high, stoned, impaired, or anything like that, and still being coordinated. This is kind of like pegboard testing and things like that, and that the patients were able to do it. There's several studies that have been done to the same level, and if you were to see at what we call the number needed to treat, how many patients do I need to give marijuana based on only these two studies? That's just a quick calculation of the number needed to treat. I will need to treat only 3 patients with marijuana to see one benefit. While if I would be doing it with serotonin reuptake inhibitors like Paxil, Zoloft, and all that stuff for neuropathic pain, I will need to treat double the amount of patients to see any benefit. The interaction with opiates, which is what we are planning to do our research, it appears to be that it's synergistic, so I could decrease the opiates because of that synergistic effect on the mu receptors that are the ones for pain, and as well as being able to even decrease some of the other things. The euphoria that some people describe as a side effect, I don't see it as a side effect. I may see it as an actual beneficial effect. It's not always an adverse event to be euphoric. In cancer patients being euphoric, it might be a beneficial thing. And then a single treatment that increases appetite, decreases nausea, improves pain, sleep, mood, and has some other potential use is something that we might want to be using it, and that's part of the reason that there's even studies. Now the group from Spain is even looking at the anti-tumoral effect. There's some studies mostly with glioblastoma, since I show you that there's a lot of receptors in the brain. The group from Spain is saying that they may have some data that some preparations may decrease the growth of the cancer. Some cancer cell line studies have also shown in colorectal, as well as some mouse studies. I feel it's pushing it a little bit. And again, I think that the different preparations are not much. Like 2 years ago, one of the duo from Chig and Chong decided that he was going to treat his prostate cancer with marijuana, with the well-known Samson oil. And I always say, like, for whoever has seen his movies, if marijuana would be the cure for cancer, he would not have got it in the first place, because he probably was getting it quite a bit. But last year when I made this presentation at a symposium somewhere else, I sat down and I did a literature search, and I pulled the terms cannabis, and there were 16,000, almost 17,000 articles on cannabis in PubMed. PubMed is kind of like the database that we use for articles. When I crossed the words cannabis and cancer, there were 517 publications, and when I only looked for clinical trials, there were 19 clinical trials, most of them of a handful of patients, that it was really not something that we can do. But the problem is that the botanical dosification, and that applies to all the integrative medicine. When I talk botanical in the office, dosification of a botanical preparation is complex. It's way easier to give an 81 milligram aspirin than to give extract of elderberry prepared in 5% glyceride, let it steep for the last 2 weeks, and then extract to the maximum concentration at the peak of the season. It's a little bit different. And the variety of hybrids, as I show you on the menu from the dispensary, it's difficult. It's even difficult to standardize because, again, the preparation of this year may not be the same one of last year. And inhaled is difficult. We've seen patients that when we give them an inhaler for asthma, they may as well use it for hairspray because they're getting as much in their lungs as if they would be using it for hairspray. There's still a lot of contamination with pesticides, microbiology, chemicals. There still is the psychoactive effect that might be problematic for some patients. And one of the biggest issues is that still is not patented. It's very difficult. You cannot patent a plant. You could get some amount of patents on some extractions, but the actual plant is not something that you can patent. And it's not something that is going to be changing. Regulation around the world is changing. This map is super old. Of all the countries in the world where it's legal medically, recreational, it is changing by the minute. Even here in Florida, the laws are changing. I was one of the first 200 physicians certified by the state of Florida to prescribe medical marijuana, and at that time, we had to take this class that it was 8 hours, that it was the most ridiculous class that anyone could imagine, until amended Amendment 2 passed, and they allow us to start prescribing. We are now part of this marijuana use registry, which it's part of the concern that people get concerned that they're getting their name out, that they're marijuana users, and the actual consent form that the state of Florida still requires, and that's the reason that I cannot prescribe it at Sinai, that I need to refer the patients to an outside institution, is because the current consent that the Florida legislation passed, it says that since the patient is being using a Schedule I substance that by federal regulation is still considered an illegal substance, if they are ever involved even in a car accident, they are resigning of their rights of being even insured. That I'm waiting for the case to come of a cancer patient with medical marijuana that gets into a car accident, and their car insurance company tells them like, oh yeah, nice to know, but we're not paying because you're on medical marijuana and that's a federal controlled substance, and your accident was while driving under the influence, and your policy does not cover you while the influence of an illegal federal substance. We're actually reporting you to be taken to jail. I'm waiting for that case to come. But that's a problem, because we're still in the limbo of the two places. The state of Florida still has some approved conditions with, again, the conditions could be as chronic non-malignant pain, so back pain still is included or anything like that. And for physicians that want to be certified like myself, we have to pay $995 to take a ridiculous 8-hour class of somebody that doesn't know half of the people that are taking the class know. This is quite interesting. My medical license is $500. I have to pay $500 to practice medicine, to prescribe chemotherapy, which is a little bit more toxic than marijuana, but $900 to prescribe marijuana to the Florida Medical Association, which is a political institution, part of the American Medical Association, which I don't want to get into the process. But again, the problem is in a lot of the different things. It's still, I would need to consent the patients to make them sign for all these things, which is much more than what we ask patients to sign when they are submitting their lives to chemotherapy or to any other substance. And then at the end of the day, if you were to compare Coca-Cola and marijuana, you have the active ingredient, THC, sugar, and high fructose corn syrup with the healthcare risk of obesity, lower immune system, dissolving bone, teeth, leading cause of childhood diabetes, obesity. It is addictive. High fructose corn syrup have extremely chemical additives. They do have artificial coloring, flavors, sweeteners. Doctors do not recommend it, and they recommend zero soda consumption, and it is sold in public schools. While the marijuana, it's good, it's got no hangovers and no carbs. So at the end of the day, the summary of this lecture, if you were to say, how does it go? 2,000 years before our days, they used to say, here, eat this root. Then 1,000 years, they said, that root is heathen. Here, say this prayer. Then 1850, they said that prayer is superstition, drink this potion. 1940, they said that potion is snake oil, swallow this pill. By 1985, they say the pill is ineffective, take an antibiotic. And by the 2000s, they said the antibiotic is artificial, eat this root. And with that, I'll be more than happy to take any questions or any further comments. Thank you. How do I monitor first of all, why do I need to monitor? And the first question is, do I need to really monitor the use of medical marijuana? I would like to monitor is that it's kept away from kids that are in teenager years, but otherwise I'm not that much. The state of Florida does make you monitor when you prescribe medical marijuana that you have to be submitting the plans and submitting the prescriptions in a certain interval that you know that the amount that the patient is using is not much more than what the patient was recommended to use, and they keep track that you actually have to submit those papers to the University of Florida in Gainesville, and they are able to track if the patient is really being using it and having a benefit. I monitor is the beneficial effect. I monitor is I tell the patient, does it help? And again, nothing is 100% in life. So I prescribe marijuana to a lot of the patients, and they tell me, no, I didn't do squat. I'm like, okay, let's try something else. So I monitor is the effect, but I don't monitor really the use. If the person tells me like I'm enjoying this way more than I should, I'm like, enjoy it. And the what? again, the problem is I cannot prescribe it legally at Sinai by the current regulation, but I do prescribe and I recommend it, and I tell the patients to get it from the different sources that most of my older patients, I just tell them, tell your grandson to get you, and it takes like 25 seconds for the kid to say like, hey, take it out. It's like, yeah. But yeah, I just recommend it that way. Yep.
How much do you see Big Pharma playing a role in keeping it a Schedule
1? The way that I see it, and as Yogi Berra said, I don't like to make predictions, especially about the future. But the way that I see it is that my feeling is that it's going to come into the point of becoming a much more available substance and almost an over-the-counter in the future, where the FDA is going to get some certain preparations that are going to be much more specific, very well controlled, to become an actual medication where they will be prescribed as a probably Schedule 2 at that time. But we are going to be seeing a movement on the recreational market and on the availability, as it's happening already in several states, Massachusetts, Colorado, Oregon, California. There's several states where you could get off a plane, walked into a dispensary, and just buy whatever you want. What I see that is going to be happening, and I see it just based on the business movements that have happened. Recently, the owner of the brand Corona bought a participation in one of the main marijuana businesses at a 10% of the business to try to start probably infusing some alcohol with marijuana products and things like that, and it's going to be moving like into a much more faster level. If you think about what I just told you and keep comparing it with alcohol and things like that, a kid now in college gets his fake ID, gets a bottle of booze, he has to share it with 20 other friends. They finish the bottle of booze and they said like, this is such a waste of time, and we paid $200 for that fake ID. Because nobody got even a little bit happy with that bottle that they all had to share after getting that with the fake ID. They get a beer of Corona infused with marijuana, and they're gonna get the buzz right away, and that's what the alcohol industry might be looking by investing in this product as well. So it's going to go in both ways. It's going to go on the medical side. I think that we're going to see much more reproducible preparations that we're going to be able to find out in our clinics, that we're going to say, let's try to use this, even if it's just the botanical preparation, but of a very controlled, specific production mechanism, and we're going to be getting the recreational movement much, much more. The biggest fear, I think that it's going to be coming from the alcohol industry than what is coming from the FDA or the pharmaceutical industry. I don't think that the pharmaceutical industry has tremendous fear of marijuana. Perfect. Thank you.